My dear colleagues, I'm Dr. Zivile Grabliauskiene, and today I want to present for you my lecture about the root apex, from radiology to biology. I greet you from Lithuania, a very small and green North European country. I am Associate Professor at Lithuanian University of Health Science, and I'm working there more than 25 years. I'm practicing in my own clinical practice and limited in endodontics and restorative dentistry. I'm living in Kaunas, the second biggest city in Lithuania. We have very nice weather in summertime, so you are welcome to visit Lithuania, and of course me. So let me do some introduction. Before this lecture, this treatment was done maybe 3 or 4 years ago. I was so happy about my high lateral canal, and I sent this X-ray to one of my colleagues. He's very young, talented dentist. He's not living in Lithuania. He's practicing in Egypt. And of course, I was to hear from him some comments about my lateral canal, but I heard a question from him. What do you think about the canal obturation? Is not too short? And actually, this was idea for me to talk about it. And I told him, actually, we have to speak about it one day. Why? Because everybody knows that distance between a radiographic apex and root canal filling material, it could be even 2 or 3 millimeters from radiographic apex. But if I will ask you, how many dentists will assess this obturation as a short fill? What do you think the answer is gonna be? I think so many. So what is the goal, the task for me in this lecture? So to change your thoughts or thinking, and from these nice white lines, so to shift from radiology to biology. And if we want to talk about biology, we have in the beginning to talk about the apical part of the canal. And these 3 millimeters of the apical canal is the most dangerous zone. Why? Because we're not talking about one canal. We're talking about the network, about the system. And morphologically, this is the most difficult part of the canal. And clinically, is a challenge even for experienced dentists. Radiographically, the place which is impossible to evaluate. And of course, cleaning, shaping, and obturation, it's very important for treatment prognosis. This is my picture of my endo treatment, and could you imagine how I was shocked when I saw this bush in the distal canal, and I said, oh my gosh, what is happening there? And I remove everything. I did obturation again, and actually I'm doing everything with microscope. My endodontic treatment starts with microscope from the opening and the restoration, and I knew that everything is clear. But actually after that I realized that I opened the network that is like this, what we can see only micro CT. So if you are doing a good irrigation, so maybe in some cases you can see this network on your X-ray after obturation. It's interesting that as more than 100 years ago, in 1908, a dentist and physician, Dr. Meyer Rain, introduced a technique for determining canal length and level for obturation. Some years after, Black suggested a measurement control to determine the length of the canal so that, listen, overfilling could be prevented. So even 100 years ago, they were very scary or afraid about to do over instrumentation and over obturation. In the first World Endo Congress time in 1953, when it was in the United States by Dr. Louis Grossman, they made some statements about root canal length, that the instrument should be confined entirely within the root canal, no over instrumentation. And the root canal filling should terminate at this level rather than at apical foramen. This level, this is like some millimeters from the apical foramen. So it's strange why in 21st century we still have a debate where is the limit for instrumentation and obturation. Now let's talk in details about the anatomy of root apex. So we have three main zones. We have the apical foramina, we have cementodentinal junction, and we have apical constriction. So let's talk more in detail about all these three parts. First of all, cementodentin junction. Could we use this position as the ideal apical termination point? Of course, it could be ideal point because this is a point where the pulp tissue ends and periodontal tissues begins. Can be observed along the entire root and not only in the apical area. And position is highly variable. You can see that in one canal wall we can see at one position, and in another canal wall it could be totally different level, so the different distance from the apical foramina. And the worst things that this cementodental junction cannot be determined clinically, only by histological examination. And usually the average distance of this cementodental junction is 1 or 2 millimeters from the apical foramina. For this reason that we cannot determine this position of cementodental junction clinically, we cannot use as our apical stop. The second point is apical foramina. Could we use it for as the ideal apical termination point? I have to tell you that apical foramina is really located at the anatomic apex and no coincident with the apex of the root. Usually, our canal is always curved apically and never ends exactly at the radiographical or anatomical apex. Location of apical foramina is only possible histologically. And the same with some anatomical features of apical root canals that could be very big distance from the anatomical or radiographical apex. And this distance could be 1 or 2 millimeters or even 93 or 4 millimeters. Some pathological condition as chronic apical periodontitis with inflammatory root resorption could eliminate the apical foramina. And we have to remember that we not have only a secondary or tertiary dentin. We have a continuous cementum deposition with the age, and this deposition, the same, could increase distance from apical foramina to anatomical or radiographical apex. And of course, we have to remember it was this picture was done more than 100 years ago, and we found that there is no one apical foramina, it's the multiple apical foraminas. So we have to remember in nowadays that we are not talking about only one apical foramina. It could be 1, 2, 3, or even more. Even 75% of the teeth can have apical ramification. So the apical foramina is not a reliable reference point for working length determination. The third part of apical area of the root is apical constriction. And some of it can call by like physiological foramen or constriction minor. And the question, could we use this apical constriction as the ideal apical termination point? This is the narrowest part of the canal. If we do instrumentation until apical constriction, the periodontal tissues is the least traumatized by instrumentation to apical constriction. The same as in apical foramina in cases of cementum deposition, the same could alter position of apical constriction compared to radiographical apex. And the same, some pathological conditions can eliminate the apical constriction as can eliminate apical foramina too. So there is two groups fighting between each other about the point, termination point, if it's good to use apical constriction as termination point. Because in that case, if we'll do instrumentation until apical constriction, we can have a risk leaving infected tissues beyond the apical constriction. I mean, in that distance from apical constriction to apical foramina. Let me present you some studies. And this first studies was done at the late of 20th century, and is written that these studies demonstrated histologically that the pulp in the apical portion of the root canal in the lateral canals and the apical ramifications remains vital and often uninflamed, even in the presence of radiolucency. So if we do instrumentation in that cases, if we have a chronic apical periodontitis till apical constriction, so this small part, so millimeters or parts of millimeters or couple millimeters from apical constriction to apical foramina, we can have healthy, not non-inflamed tissues. Another study, the new studies from 2018, that the viable portion of radicular pulp tissues may be vital and non-infected. So despite necrosis and bacteria establish themselves in the periapical tissues, the instrumentation and obturation should remain at the constriction. So it's the same as was said at the end of the 19th century. There is no any changes. Why I told you that this is the same like from the end of 19th century. This article, I found it published internet. I don't remember exactly where, but it was from 1880. And even in this article is telling us about apical constriction. Please read carefully here. It's about obturation, but look. Of gutta percha previously prepared and cold this passed as far as possible into the canal and with warm wires packed to very end. They were doing vertical hot condensation. You can imagine? When the sealing is pressed against the apical constriction, it generally gives a little pain, which is a satisfactory showing that the canal is full. Pressing till apical constriction. So the ideal apical limit for the working length has been recommended as the apical constriction in most of the studies. Actually, is another problem, but it is frequently impossible to know exactly where the apical foramina and apical constriction are located. How to determine the position? So it's as for us as for clinicians is a normal question how to locate the apical constriction if it cannot be located clinically. Very old methods for all times is tactile sensation. This results from study done in 1975 that experienced endodontists could detect the apical constriction in 60% of the cases. However, the anatomical variation in apical constriction, location, size, type, tooth type, and age making working length assessment unreliable. In some cases, the canal sclerosite or the constriction had been destroyed by apical resorption. So, could we use a tactile sensation for determining the position of apical constriction? I don't think so, because in that case, we can have a questionable success of our endodontic treatment. Another method, the same, very old, is moisture on paper point. When you're inserting a paper point, while extracting, you are measuring, and these millimeters of blood or liquid tissue liquid on it. It's showing that you are beyond the apical constriction. However, I don't think so that this method is reliable, and we can use it for our working length determination, because if we will use it, we will have a questionable success too. The third one is radiographic. So this is a two kinds. It's conventional radiography and digital radiography, and still some dentists are using conventional radiography. So even doesn't matter what kind of radiography you are using, or conventional or digital. So the accuracy of radiographic locate the apical constriction, because we have to locate the apical constriction, because this is our point. When front teeth is possible only approximately 33% of the cases, in premolars 32% of the cases, and in molars only 15% of the cases. So can we use it to locate it? Let's have a look at another investigations. Actually, I think so. These slides are using many dentists when they're talking about working length determination and radiographic examination. So files determining at the radiographic apex in vivo had actually extended beyond the apical foramina in 50% of the cases. So if you have X-ray on your instrument or your good aperture reaching the end radiographical apex, it means in every second case you are over the apical foramina. I'm not talking even about the apical constriction. Adopting the radiographic apex as a reference point would result in over-instrumentation and over-obturation. This photo was made by my wisdom tooth, lower third molar. Actually, it's a funny story. It's a funny story because I had a pulpitis pain. I decided, I diagnosed for myself that is from premolar, because a premolar had a big feeling, and I had like a pain from sweep for 2 years or something like this. So I misdiagnosed. It was not premolar. But even for this premolar, my colleague, I told her to do a pulpotomy. So she did a pulpotomy. However, she told me that, oh my God, it is a healthy, totally healthy pulp. There is not even inflammation. So after this pulpotomy, I still had a pain like for 2 days. And I decided to do an X-ray, and it was a big caries from the distal surface in a third molar. So of course, I extracted, no, not me, but my colleague extracted it, and I wanted to do some experiments. So I did instrumentation of the canal. In the beginning, I wanted to determine the working length and made this X-ray. You can see that my instrument is exactly at the radiographical apex. But if you see, like with your eyes and normal eyes, you can see that this instrument is beyond the apical foramina even. It's over. And as I told you, don't forget that you never have apical foramina exactly at the end of the anatomical apex or radiographical apex. It's always curved. It's always curved. So some dentists thinking that we can adapt our working length for instrumentation obturation according a diagnosis. If, let's say, we have an endodontic treatment for teeth with vital pulps, so the instrument could be even 2 or 3 millimeters shorter than radiographic apex. And in cases if we have necrotic pulps, so the distance, it must be smaller, only 0.5 or 1 millimeter shorter than radiographic apex. And you have to remember all the time that over-instrumentation reduce the healing rate on conventional non-surgical retreatment cases and lead to development of new apical resorption and apical destructions. Clinically, if we will set the working length 1 millimeter short from the radiographic apex, the apex may position the file exactly at the apical constriction the same, only 22% of anteriors, 35% of premolars, and only 11 of the molars. What does this mean? It means that if our instrument is 1 millimeter shorter than a radiographic apex, even in that cases, we are not exactly at the position of the apical constriction. So radiographic image does not allow observing the position no of apical foramina and no for apical constriction. So it's normal question. Do we need the radiographic images if we cannot determine the position no apical constriction, no apical foramina? I think so that the preoperative radiograph is essential in endodontics to determine the anatomy of a root canal system. This is a lower canine with 2 roots. The number and curvature of the roots, I say missed 1 root, or presence or absence of disease, and could be as an initial guide for walking length. Of course, we have to know the average of root canal length too. But you have to remember that or conventional or digital radiography have some limitations. First is the distortion of the normal length of the tooth. It could be magnification. So in some cases, you can have a smaller tooth, or in some cases, you can have a longer one. So it depends on technique, how you're doing X-ray. So it could be parallel or could be semi-angled. So I suggest you to do always parallel, with exception only holders. Use a holders all the time. So in that case, you will have size or length of your tooth in the X-ray approximately the same that is in reality. Another limitation of the X-ray that the root canal system it could be superimposed radiographically by anatomic structures. So we have some anatomical structures in maxilla and the same some anatomical structures in mandibular. So when you're reading an X-ray, you always have to keep in your mind that could be some anatomical systems like arbus zygomaticus that could block your root canal ends. In that case, you cannot even determine if it's too long or too short your filling material or your instrument inside the canal. I think so that the worst thing for our digital or conventional radiography that is only 2-dimensional image. And the tooth is a 3-dimensional structure. So in some cases, we need to do a CBCT scan. This case was from my friend. I did retreatment more than 10 years ago. And it was very nice. You can see I'm very happy with my canals. It was some post and it was a crown on top. The crown, I taught them restorative dentistry. I'm not prosthodontist. So he came with a pain and with a swelling, and we did a periapical X-ray, and I saw some changes in radiolucency in the next to buccal apex. So we decided to do apicectomy. And in the morning, I started to have some doubts about this periapical X-ray, and I asked my patient to go and to do a CBCT. And on CBCT, we had a resolution of big lesion. It was not only next to medial buccal root end. It was in between palatal and mesiobuccal root end, and of course, even it was inside the sinus. So after extraction, I saw many of fractures of the root, and you can see here the color changes of the root. So don't be afraid. This is a Russian red root. This is some treatment of resorption formalin. So it means that the treatment for this patient was done first endo treatment with this method was done maybe 30 years ago. Another limitations is about interpretation, how we're reading an X-rays, because I think so. It's like some kind of art to read an X-rays. And this study I took for you as an example, cause was some observers for this investigation, and the agreement about diagnosis was only between observers 66% of the cases. So I think so that most on the every second case they didn't have an agreement. So this is the same limitation. Another limitation is that you need to have a clinical experience. This is a study about influence of clinical experience on the radiographic determination of endodontic working length. Was some groups undergraduates of 2 stages of training and endodontic postgraduates, and a gold standard for use experienced endodontist. And of course, the most experienced group was significantly more accurate than the another group. So the same, our clinical experience had very big influence of determination of working length from the X-ray. So anyway, to locate the apical constriction on radiographic images is impossible. You can see only that is your instrument inside the canal or outside the canal. Even in some cases, you cannot tell it. To use the radiographic method for working length determination is unreliable and doesn't have any biological confirmation. So if you will use only radiographical methods for working length determination, the same, you could have a questionable success. Some conclusion from studies then from 2001, using radiographic working length calculations alone led to instrumentation beyond the apical foramen in 56% of the premolars and 33% of the molars. The accuracy of working length determination is affected by several factors, so a combination of methods is recommended for determining the best working length. So this is a recommendation or a guidelines from European Endodontic Society. So the quality guidelines for endodontic treatment, and it's about working length determination. So the same, they are writing that the location of the apical constriction, we are talking about apical constriction, and it could vary 0.5 or 2 millimeters even from radiographic apex. As a first methods for working length measurements, they introduced electronic. So of course, for everybody now it's really clear about what I'm talking. And I'm talking about, of course, apex locator. Actually, it's interesting that this differences in resistance was found is not in the middle of 20th century. It even was in the beginning of 20th century, and even only in 1962, Sunada constructed the simple device that can show for us the difference between pulp and periodontal ligament according measurements of their resistance. So this method can help us to measure exactly the position where our pulp tissues end and the periodontal tissue begins. Another question for us as a clinicians, how readings of apex locator are accurate? Another question, can I trust those readings? Usually many of dentists asking me what kind of apex locator you're using. It doesn't matter. I have many apex locators, not many, 2 or 3. And my students, the same at university, they always complaining about apex locator. Oh, professor, can you help me? It doesn't work. It doesn't work with it. Usually it's not a problem with apex locator, usually a problem with the operator. If you will read many published articles about apex locator, they usually have a conclusion that the readings of apex locators are clinically accepted for working length determination. And the same, all electronic apex locator, doesn't matter which company, showed an acceptable determination of working length determination between the range, listen carefully, plus minus 0.5 millimeters. And even there is no, there's another studies from 2017, they tried to see a difference between how many, some apex locators, and they didn't find any differences. But actually, what was interesting, the accuracy you can see was 64%, 53%, 64%, and 50%. And the same with the range of accuracy, plus minus 0.5 millimeters from the working length. So, according different trials, the accuracy can vary from 63% till 96%. But what's the problem with average acceptable range plus minus 0.5 millimeters? What does it mean for us clinically, this 0.5 millimeters? If we'll go longer, this 0.5 millimeters biologically is not acceptable, and we can have clinically postoperative pain. If we'll go less than 0.5 millimeters, in that case, we have a risk to leave in infected tissues, not cleaned. So, could we accept this measurements range 0.5 millimeters? I think so, that should be reconsidered of this margin of 0.5 millimeters if you want to have a really right working length measurements and clinical acceptable measurements. All the apex locator determining the apical foramina. And it's a very easy, but the main question, we don't need the apical foramina. What we need to find an apical constriction. And the distance from the apical foramina to apical constrictions, 0.5 millimeters, is only in 46% of the cases. Could this range, a distance from apical foramina to apical constriction, could be even almost 4 millimeters. I mean, this distance could range from 0.2 till 3.8 millimeters, this distance. And of course, this distance could increase with age because we had a cementum deposition with the age. And you can see this, this result from the study is a distance from apical foramina to apical constriction. This is a root type, mesiobuccal. So the distance average 0.37, 0.34, 0.3, 0.4, and the same, even the apical distance from apical foramina to root apex, the same, have some distances. So what average, what we are using in our clinical practice, 0.5 millimeters, is unreliable and unrealistic, because every tooth have a different distance. So we cannot use for all the teeth this average 0.5. So please always read the instruction of your apex locator. Each machine is marked differently and records the apical constriction and apical foramina at different locators on their readout scale. Always calibrate your apex locator. What does it mean, calibrate your apex locator? It means that all apex locator told you are showing for you the apical foramina. Usually the apical foramina is exactly where a flashing bar or red zone starts, or some noise or sounds beep. So it means exactly at this place you have your apical foramina. So a question a question, where is your apical constriction? What I did with my apex locator, so I inserted my instrument. I measured the apex with apex locator, the apical foramina until my flush red bar was appear on my apex locator scale. I took off the instrument from the canal. I reduced my instrument for 0.5 real millimeters because our apex locator has showed not millimeters, it's just marked. 1, 2, 3 is no millimeters. So I reduce exactly real 0.5 millimeters from this length from apical foramen just to have an average. But even I know that is only average, I will not succeed with it. And my apex locator showed me that the first green line. So I calibrate my apex locator and I'm working always at this line, at this number 1. It's not doesn't mean that it's 1 millimeter. Yes, it's just a mark. So in this case, I have a perfect. Now I'm much more satisfied with this length that I was showing this big slide with many obturated canals that I'm not so satisfied too much. So you can see this is a measurement, my first green bar. But I told you this is my apex locator. So your apex locator could show you totally different mark or flashing bar or whatever. So mark, the first red is your apical foramina. So remember. But as I told you, anyway, 0.5 millimeters is the only average, but this could be only 46% of the cases. So the same as simple case, this is my apex locator. I was cleaning a distal canal, and it's very, why I put it this X-ray, because it's very clearly see that the apical foramina or the canal is curved. It's not end here, and maybe from the big X-ray it looks like it's too short, but now I can see here clearly that my apex is curved, and my apex locator you can see clearly shows a first green bar. This is my instrumentation, and I'm using the paper point technique. I dry the canal, and you can see all my paper points are without fluids and without blood. So I combined for working length determination two methods: apex locator and paper point. I don't like to do x-rays with my instruments because I told you it's not reliable. I don't know exactly where's my instrument, or my instrument is at apical foramina or at apical constriction and somewhere in between. Actually, it's interesting that we have already in our market a 6th generation of apex locators. And if we have a not this very new apex locator, so in some cases intact vital tissues, inflammatory exudates can cause inaccurate readings, yet it could be even a very new apex locator. So the most accurate readings is in the dry canal. However, readings are accurate when the canal is wet with the presence of blood, saliva, or irrigant. What is my suggestion? If you can see that your apex locator is not working properly, just dry or only the pulp chamber. Because usually my pulp chamber is always like a pool with irrigator solution. So just I'm blowing my irrigator from the pulp chamber. I'm not drying the canal. It's enough if you're working with new generations apex locator. So there are some factors that can change or distort the working length measurements. So this is depend on canal shape, the accumulation of dentin debris. And it's very important because there is no any instrument in the dental market that could take all the dental debris from the canal out. It's always you have and dental debris packed in the apical area. Even you will work with reciproc instrument, even you will use some expanded type of instruments, you always have some debris. And calcification of the apex can affect accurate working length determination. Actually, I have many cases from the referred patients from another dentist that they're telling me that, oh, please go through whole walking length, and they're giving some x-rays for walking length determination, the instruments, and it's like not enough, or the instrument stopped like 2 millimeters from radiographic apex, and they ask me to go for whole walking length, and usually the patient is telling, oh, my dentist did all kind of job, and you now need to go only 1 millimeter. Actually, if it's so easy and to go 1 millimeter, why he don't to finish and to do it with 1 millimeter? But actually, he forgot that this could be some calcification, or it could be some anatomical features of the canal, because the heaven could be wide. We can have a apical constriction, or sometimes we have a full calcification. It's normally, and I don't know how to create a canal in this calcification cases. So this is my next lecture about this calcification and how to do endo treatment, or do we need to do endo treatment on this. The same which factor is a lack of patency. This is a problem for my students all the time. They are blaming the apex locator all the time. The professor of apex locator doesn't show me, or the scale is showing some nonsenses. One time 0.1, one time 0.5, another time 1. Usually this is a problem that the instrument is not touching the canal walls. It means that the canal itself, it's much wider when you inserting the instrument. The instrument should touch your canal wall if you want to get correct measurements of walking of apex locator. So in some cases, when you have a naturally anatomically wide apex, like in molars, distal or palatal canal, or canine, or central incisor, when anatomically is a natural size is a 50, so don't insert number 8 and try to measure the walking length. It could be, of course, but only if we had a canal calcification cases. So try to take a bigger instrument, that the instrument could touch canal walls. Another factor that can show for some not right walking length measurements is incompletely formed or closed apex. In that case is when we had an open apex. So the same, we had a like big possibility of tissue fluids, periodontal tissue fluids inside the canal, and the same, in that case we don't have a no apical constriction, no apical foramina. Actually, but there's a relatively little data regarding the value of radiography and electronic apex locator used when root formation is incomplete. So of course we need still some studies. What about inflammatory root resorption? What about our walking length determination in case when we have a root resorption? So you can see that the accuracy of determining the correct walking length is decreasing compared to normal one. The same, you can see limits 0.5 millimeters. I can show you, and when you have this limit is more accurate. And actually, the conclusion of this trial, that neither of two apex locators were 100 accurate in determining the walking length. So actually, for me, it doesn't matter 56% or 33%. It's not accurate 100%. Actually, in the medicine, you saw many cases there is no accuracy in 100%, or treatment success cases in 100%. As I show you that slide before, the treatment, the accuracies from 63% till 95%. So if we have an inflammation root resorption, so the accuracy is dropping. So the electronic apex locator cannot replace radiograph, but will definitely serve as an effective adjuvant. So what to do in that cases when an apex locator readings does not match with the image of X-ray. Because I told you that from guidelines from endodontic society or European endodontic society, it was the first mentioned apex locator, and the second one was radiographic. And in some cases, like I'm using, I'm working for my students, I'm telling them that you have to do like 4 X-rays. One is preoperative X-ray, the second one for working length determination, the third one for gutta-percha determination, and the fourth one after obturation. So usually, if want to be honest with you, I am skipping 2 middle X-rays. I'm doing only preoperative and always after obturation. This is like obligatory with 2 X-rays. And if I have no doubts about my electronic apex locator readings, I'm not doing no with instruments, no with gutta-percha. But I have to be sure about my apex locator's readings. But in that case, if you are not experienced endodontist, I suggest you anyway to do after locating, after measuring the working length of apex locator, do X-ray with the instrument inside. So in some cases, the apex locator reading does not match the images of the X-ray. So sometimes the instrument could be significantly shorter, even more than 3 millimeters, than the radiographic root apex. It means if it's less than 3 millimeters, it could be normal, because you remember we were talking about the distance from radiographic apex to apical constriction, and it could be even until 3.8 millimeters. So if your instrument is shorter, less than 3 millimeters from radio apex, is a normal. But if it's less than 3 millimeters, so in that case, repeat the measurements with the apex locator and believe in its reading. Okay, I have an X-ray. Oh, my instrument is more than 3 millimeters from the radiographic apex. So I am measuring again, and of course I am trusting apex locator. I don't think so that you have to repeat again an X-ray, because it will be the same what you got from the first X-ray. And the statement position from European Society of Endodontists that the length should be adjusted and confirmed by another radiograph if you want to be totally sure. It's only suggestion. It's not like obligatory you have to do it. Like I told you, I'm always in the beginning trusting apex locator. What to do if an X-ray your instrument exactly at the radiographic root apex? I want to remind you that in 50% of the cases, instrument is usually over anatomical apex. Measure again with apex locator, and you have to believe in its reading. And what to do if the instrument is beyond the tip of a radiographic root apex? In that case, I'm telling that it's something wrong with the operator, it's something wrong with the dentist, or you are deaf, or you are blind, something like this. So in conclusion, none of the technique or the electronic or conventional or digital radiography was totally satisfactory in establishing the true working length. An exact position of a file tip can be determined only when the teeth are histologically examined after extraction. And when my patient asking me about some guarantees, I said, okay, I cannot give you any guarantees, because even I don't have exactly method for working length determination. Is not enough one, even is not enough two. Of course, the best one is to extract the tooth, to check it, but actually no endo needed, no endo treatment needed after that. So no individual technique is truly satisfactory in determining walking length. So it's very important to have apex locator. You have to trust your apex locator. Work with it. Try to do your measurements on. So the same from another position is your X-ray, radiographically, measurement of walking length determination, and between these two methods is the operator, is a dentist, is you, and of course, a tactile sensation and blood or tissue fluids on paper points. So we have like 5 methods. No one of these methods cannot be used alone. No apex locator, no radiographic images. It's very important to have all these 4 methods and measurements or some conclusion from this you have to put in your head, go through it, and do a decision, because you are an operator, you are a doctor, you will do instrumentation and obturation. So usually if we have some errors in walking length measurements, it's happened because operator errors. This is what I found it in some paper from European Society of Endodontology. Molars treated by endodontists after 10 years have significantly higher survival rates than molars treated by non-endodontists. And in the process of walking length determination, the main source of measurement error was the operator and the procedure itself. Like I told you before, this is I found it later when I created another slide. I told you that always is usually in most of the cases operator errors. And this is a nice study. You can see that it was done investigation of mostly 5,000 root canal therapy. And the same survival rate of endodontically treated teeth are higher at 10 years after treatment, regardless of provider type. We are talking about treatment done by endodontists. I don't want to tell you that if you are not endodontist, you can do a good endo treatment and to achieve good endodontic treatment results or predict some results. Sure not. Endodontists usually need it when we have some complication. It's not like for initial root canal treatment. But as for me, if you will ask me, for me, it's much more difficult sometimes to do initial root canal treatment for molars with 4 or 5 canals than to do some retreatment or bypassing instrument or retrieval of instrument or something like this. So because you have to remember one thing, that the most complications occurs in the time of primary endodontic treatment. When we have retreatment, we are already working on complications, what happened in primary endodontic treatment. So my slides the same from like beginning of my lecture. Do I'm satisfied with all these cases? I put these cases on my Facebook, and I was so proud of these cases. Do I pride of my cases now after this lecture, when I know the limit of instrumentation obturation? I know about biology. I don't like this. 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 This is I like. This is I like. This is I like. So let's change together with you our concept of endodontic beauty. The pearl is not has biological puff. We usually told we are very happy about the sealer, It doesn't have any biological consideration. You can see the study, histological study from Dr. Domenico Reccucci. I'm following his studies. I'm very like his work. And you can see that here's a radiographically, it's overfilling, it's minimal radiographically. It's only small amount of the sealer are there. And you can see here on X-ray that this instrumentation was done at the apical foramina. There is no apical constriction. The apical constriction is destroyed, and we have some granulation tissues around this sealer. So if I'll ask you, what is better to put some small amount of sealer or to do some big overobturation of the gutta-perca point? And I think so that you will answer, of course, maybe the sealer, but actually, if you want to remember about chemistry of the sealer, and if you remember about the gutta-perca, but is because it's very has big biological consideration with tissues, human tissues. So, and all sealers is very toxic, at least until they are set. I'm not talking about calcium silicate or hydraulic sealers. I'm talking about usual sealers or resin-based sealers. So maybe in some cases to do over obturation, sometimes it happens. It's not an intentional. It's not intentional. It's not unintentional. So it happened with my case. Actually, I don't know how it happened, but it happens sometimes. The same. The complication happens to me too. And the patient actually was not complaining about any pain after obturation. Now I can see that it's clearly seen that this gutta-perca it's too long. It's actually the X-ray after follow-up 8 months, and you can see that the granulators are doing their job, and you can see the separation next to this main gutta-perca. I told you this is not my prosthetics. I'm not doing prosthetics. It was only my canal. So sometimes we cannot avoid some mistakes or some over obturation or some over preparation, but we have to think, and we have always to think from the beginning until the end. It looks like for patient we're doing some like mechanically job, it's like we have a protocols and we don't have to think. But every case is individual. There is no protocol for every case. Why are you telling that there's no be any robots or some machines that could replace the dentist? Never, because even every tooth is different in the patient mouth. So in the case, according to situation and morphology and anatomy and diagnosis are different. So what I want to remind you, I think so it's could fit not only in dentistry, not only about working time determination, but in many cases in life situation, that wrong is wrong, even if everyone is doing it. Can see obturation, and right is right even if no one is doing it. So instead of conclusion, don't believe what you hear. Don't believe in anything that has been repeated many times. Don't believe what is written for all times. Don't believe in any guru authorities. And now full of Facebook of guru. But always put a question when you're doing something. Why? Why I have to do it? Why I have to do it or use it? Not how, but why. And after careful observation and analysis, when it is not contrary to common sense, your knowledge and perception, accept it, work, and live according it. So with my best regards, good luck in your clinical practice, and maybe see you one day in any live conferences. Thank you very much for attending my lecture.